In this video, shared by Dr. Rodrigo Sato from São Paulo, Brazil, we will discuss the surgical management of a case of vitreomacular traction syndrome in a diabetic patient. This is the case of a young diabetic patient with progressive vitreomacular traction syndrome, which prompted surgical treatment with pars plana posterior vitrectomy. The surgeon begins with vitreous circumcision. Next, the process of segmenting the areas of vitreoretinal traction is initiated. At this point, the vitreous cutter is used to isolate the area of vitreomacular traction. By increasing the vitrectomy probe cutting rate and decreasing the vacuum, adequate control is achieved at this stage to avoid inadvertent traction on the macular region. It is important to carefully circumscribe the macular area, as abrupt aspiration of the posterior hyaloid may lead to the iatrogenic creation of a macular hole. Next, segmentation of the juxtapapillary traction areas is performed. At this point, delamination begins. The surgeon chooses a bimanual delamination technique using forceps and scissors. An appropriate plane is found for dissection of the fibrovascular tissue, avoiding iatrogenic tears. As this is a highly vascularized tissue, bleeding is expected at this stage. Hemorrhage can be controlled by increasing intraocular pressure and aspirating with the vitreous cutter. After delamination of the fibrovascular tissue is completed and the bleeding points are controlled, vitreous base shaving is performed. A fluid-air exchange is carried out. Finally, panretinal photocoagulation is completed with endolaser, and the vitreous cavity is filled with 20% SF6 gas.